Welcome to my YouTube channel. Today we are going to talk about latent TB. So, uh, just let's go through just this diagram and we see what this diagram just says. So, when a person gets infected with TB, they develop primary TB. That is the first time. So, 10% of those people will undergo that is active primary TB, while 90 of them, the infection will be controlled by the immunity, and later now they'll develop latent TB infection, which nowadays is called TB infection. So, a percentage of the people, the infection will get controlled by the immunity. So, just a brief of where we are at now. So, person gets infected by TB, which is aerosols that are contaminated by the bacilli, and then they inhale, and then arrives at the lung. Then, 10% of the people get infected. 90% of the infection gets controlled, and a part of them gets cleared by the immune system. So the people who get control, that is called latent tuberculosis infection, or the newer term that is tuberculosis infection. So this tuberculosis can either stay just as latent or later can get reactivated. And there is where we call secondary tuberculosis. So the circumstances that will cause this tuberculosis to be reactivated are, for example, reduced immunity, patients who are taking immunosuppressive, or patients who are HIV positive. So later then you can have local case or after reactivation, the disease can progress to spreading and later you get miliary tuberculosis. So I hope you have understood the progression of this disease. So as I said before, latent TB, which is commonly now known as TB infection, is when the infection has been controlled by the immune system. So the person has the infection, but now it's controlled. So this person is asymptomatic, and there's evidence of cell-mediated response. So it occurs when a person breathes in bacteria, as you've mentioned, enteration the air sac, that's the alveolar, and the immune system keeps the bacilli contained and under control. And the person is not infection and has no symptoms or signs. So TB disease, we're going to talk more about it, but you can just pass through the slides. It starts by replication in the macrophages, and primary infection occurs where we have cell-mediated immunity gets activated, and then now you form, and then surrounds the cells and you form granulomas, and then this leads to necrosis of the tissue at the infection site that forming the gone foci. This is just pathophysiology, which lead with if it involves the nearby lymph nodes, you'll get a complex, and if they calcify, you can also get calcification of the gone complex. So this is just the difference between latent TB infection and TB disease. Currently, it's called TB infection. We don't know the latent. So both you have tubercle bacilli in the body. Both there's activation of the cell-mediated immune. So when you do TST, that is, and the IGRA, they'll be positive. So the chest X-ray for latent TB it's normal. However, chest X-ray for disease is abnormal. The sputum and the smears are negative because it's controlled, where this one are positive. You say there's no symptoms. The patient may present with symptoms in the disease in terms of cough, fever, and weight loss. In latent, the patient is not infectious, while in TB disease, the patient is infectious. In latent, the patient is not a TB case, while in TB disease, this is a TB case. So what are these risk factors that will predispose one to be infected? So is, for example, you come in close contact with person who is infected with TB, patients who are skin covectors within the past 2 years, recent immigrants from TB endemic areas, children who are less than 5 years with a positive TST, residents and employees of high risk places, for example, people who are at prisons, healthcare, uh, people who live at shelters. So these are just risk factors that predispose one to the infection. However, now when you're infected, as you have talked about, that we have two phases where the patient gets infected, and after infected, they develop three outcomes can occur, where the immune system controls the infection, where the immune system gets rid of the infection, and where the patient enters active phase. So what predisposes this patient who is now infected, or latent TB from progressing to TB. So mostly it's patients who are infected with TB, patients who uh, they were in latent phase and they were not treated, underweight or malnourished patients, patients who use injection drug use, those who are receiving TNF alpha antagonists. These drugs are immunosuppressive and patients with certain medical conditions. In addition to patients who are lesser than 5 years. So diagnosis, we do screening tests for latent TB infection, a newer term TB infection, considering the risk factors to determine who to screen. So we consider the risk factors to determine who to screen. And the goal of screening is in order to identify if the patient is in latent TB. And when you identify if the patient is in latent TB, then you treat. You just don't screen just for the sake of screening. So the tools we use is TST and interferon gamma release assay test. These are the common used in patients. So if the patient has previous history of BCG vaccine, then obviously whether they are infected or not, their TCST will come positive. So IGRA is a useful test to distinguish between BCG vaccine and positive latent phase TB infection. So all patients who are HIV and those who are immunocompromised, then they have to be screened for TB infection, that is the latent TB infection. And the truth we just don't use TST, but we also use TST and chest X-ray or IGRA and chest X-ray. Reason behind this is because most of these patients are predisposed, actually highly predisposed to TB in itself. So we aggressively diagnose so that we treat them so that they don't go to TB disease. Interpretation. So after now we have done these screening tools, how do we interpret them? So IGRO, that is the interferon gamma release assay. If it's positive, then it's likely that this patient has TB infection. Then what the next thing that you do is chest X-ray. And then if it's negative, it's unlikely that they have TB infection but cannot be excluded. So TST, if it's positive, also the patient is likely to have TB infection. If it's negative, then the patient is unlikely to have TB infection. So depending on the characteristics of the patients, obvious, I have a video separate talking about more of TST because its interpretation is not more of positive or negative. Its interpretation is more of what can we see, how much is the inturation. So in some patients 5 and 10 and 15, but in patients who are healthy and have no risk factors, then the inturation greater than 15 can be taken to be as negative. Reason behind this is because you get patients who are predisposed, for example, patients who are HIV positive, patients who are immunocompromised. If we get an intuition of 5, then it means then there's some of the cell-mediated immunity. So that's how we cannot just ignore it. We now go forward and do a chest X-ray to exclude it. So and patients who have now intermediate risk for getting TB, if it's greater than 10, then we take it as positive, and patients who have greater than 15, we also take it as positive. However, in patients who are healthy, in duration of and no risk factors in duration of less than 15 ml, then is negative for TB. So how do we manage now? After now we have our results. So if patients who has a positive immune gamma release assay test or a positive TST, you do a chest X-ray. If the chest X-ray is normal, then you treat as TB infection. However, if it is abnormal, you work up for active TB. If the IGRA and TST is negative, then and the patient, because we have talked about the risk factor, and the exposure is less than 8 to 10 weeks since immunosuppressed, so since exposure, then you have to look, is the patient immunocompetent or immunocompromised. So if the patient is immunocompetent and is greater than 5 years, then you don't treat. However, if the patient is immunocompetent and is less than 5 years, you start treatment for latent TB infection until you repeat the two tests 8 to 10 weeks. Now afterwards, following exposure. Now after you repeat the test, if it's positive, then we go back to here where we said if it's positive, you do a chest X-ray, and if the chest X-ray is normal, you stop treatment, and if it's abnormal, then you work up for active TB. Um, then um, if the chest X-ray is normal, you continue, you finish the treatment with TBI, and then if the chest X-ray is abnormal, then you work up for active TB. However, if after 8 to 10 weeks your patient comes and the tests are negative, you stop the treatment immediately, because we said immunocompromised and patients who are 5 years, you start treatment regardless of whether the test is negative if the patients have been exposed in less than 8 to 10 weeks. So, however, for patients who we said here, the TST is negative and IGRA could be negative, and then after still repeating the test, they still become negative, and then here we said you stop the required treatment, we would advise that you continue finishing the treatment for patients who are HIV positive. If patient the exposure is greater than 8 to 10 weeks since exposure, then there is no further evaluation. This is because if the patient is less, that is less than the exposure is less between 8 to 10 weeks, then the delayed cell-mediated immunity has not yet been developed. So we give it time. That's why we repeat the screening test. So how do we treat? So before prior to treatment, if your patient now you have gotten they have positive TST or positive IGRA, and the management that you're talking behind, prior to treatment you have to exclude TB disease. So if you have noted that if you get a patient who has positive TST and positive IGRA, then you do a chest X-ray. Then if the chest X-ray is abnormal, you work up for TB. This is just all about we have to exclude TB. In addition to that, you also have to exclude TB in terms of symptoms. Do they have fever? Do they have cough? Do they have night sweats? And also physical examination. So how do we treat? There are shorter regimens and there are longer regimens. The most preferred regimens are rifampin-based regimens, and we have the following. This is 4 months, this is 3 months, and this is 3 months. So the four months is daily rifampin for 4 months, and then the 3 months is once weekly isoniazid plus 1 weekly rifampicin for 3 months, and then 3 months also daily. You give daily isoniazid plus rifampin for 3 months. So you just choose one. So I've seen most people choose daily rifampin for 4 months, or they just do daily isoniazid for 9 months. That is the longer treatment. So according to the location that you are, you follow your clinical guidelines. So monitoring, because these are drugs, and they as much as they offer solution, they come with their effects, that is the adverse effects. So both isoniazid and rifampin have hepatotoxicity, but noting that isoniazid is more hepatotoxic compared to rifampicin, and you have to, yeah, though the hepatitis risk is greater than true, as I've said. In addition to that, you can also have rash and the thrombocytopenia, which is immune mediated. So you discontinue the treatment if patient is asymptomatic of hepatitis and they have elevated serum transaminase, that is AST and LST, or greater than 3 times upper limit. And if the patient is asymptomatic and the transaminases are elevated 5 times the upper limit.